Okay, so hello, and I'm Donna Coyle. I work for the Wales Co-operative Centre. I'm the manager of our projects that combine social care, social support and cooperation. A genuine big warm welcome to this hour-long webinar. We will provide an overview of our new report, supporting care commissioners and procurers to promote social value models, and start a conversation on how its recommendations can be implemented. I'd like to acknowledge Welsh Government as the funder of the report and of this second phase of the project, the opportunity to work with you on practical solutions to promoting social value. Welsh Government commissioned the Wales Co-operative Centre to deliver the project. We invited Adrian Roper from Cartrefi Cymru Co-operative to bring his experience and enthusiasm to the project team. We have a tight agenda that doesn't allow for Q&A or discussion, but please do post your observations and questions in the chat as we will happily respond after the event. This session is the start of phase 2 and a programme of workshops that we hope you will sign up for. After today, we will send a form to ask if you would like to work with us over the next few months and to identify the subjects you'd like to explore and develop in more detail. The whole project is about collaborative learning, and the report is the story so far. Now I'm going to hand over to Adrian Roper to share some of the report's findings. Thank you.
Okay, hope you can all see the screen. Hi everyone, this is the title of our report, and I'm going to take you through the narrative part, which addresses the whats and whys of social value models and sets out an agenda for how they can be promoted. First up, a big what. There is no single agreed definition of social value. For some, it is about what is important to the end users of a service. For others, it is about extracting additional community benefits from a supplier. In social care in Wales, it has been used to create phrases like social value organisations and social value forums, but the result has often been arguments about who should be included. These phrases have been used as shorthand for organisations referenced in section 16 of part 2 of the Social Services and Wellbeing Act. It's therefore helpful to have a closer look at what section 16 actually says. I'm not going to read it all out, but the wording of the Act actually describes 5 models, and only 3 of them are organisations: social enterprises, cooperatives, and other third sector organisations. The inclusion, as I've highlighted in red, of cooperative arrangements as well as cooperative organisations within the section 16 duty encourages authorities to consider the potential value of arrangements that might extend from informal self-help groups to multi-agency consortia. And the use of the phrase user-led services in the heading rather than user-led organisations should also be noted, along with the emphasis in the wording of the duty on user involvement in the design and operation of provision. Whilst user involvement might be particularly likely in a user-led organisation, the Act is encouraging the promotion of a user-led approach in all organisations. This pan-sector challenge is important because section 16 and the whole of part 2 of the Act is intended to support the transformations of services in Wales so that they achieve the best possible outcomes and are more financially sustainable. A focus solely on not-for-profits would mean excluding a massive part of the care sector from this agenda. Pragmatically, both commissioners and citizens need for-profit agencies to operate confidently both now and for the foreseeable future. Some for-profits are also exemplars of quality and innovation. It makes far more sense to engage for-profits in a process of improvement and transformation than to leave them outside. And section 16 opens the door for this. But there is a price of entry. The codes underneath section 16 make it very clear that there is an expectation of values and behaviours which reflect the principles of the Act. So whatever sector or business type an organisation might be, it needs to demonstrate its commitment to these principles. Above all, They should be striving to work with people in accordance with the principles and practice of co-production. Co-production is writ large all over the codes. It is the key tool for achieving great well-being outcomes and long-term sustainable services. For-profit organisations should also reflect on the implications of adopting co-production principles for their governance. Genuinely empowered users of services are likely to ask questions about what happens to profits made by their support provider. They are likely to be strong advocates of profits being reinvested into quality of service and fair pay for care workers. At some stage, we might expect the best of our for-profit care providers to re-examine their constitutional identity and remodel themselves around a clear social purpose. But in the meanwhile, they should be encouraged to explore the benefits of cooperative arrangements and to involve users in the design and operation of their provision. But let's have a quick look at the 5 principle-based goals from the Act that underpin the Section 16 duty and surface why not-for-profits might have an edge. The Act wants to see providers that can deliver great well-being outcomes and do what matters as end users define it. Many not-for-profits were set up to do exactly this. The Act wants to mobilise people as co-producers of their own well-being and the well-being of the wider community. Many not-for-profits have strong local connections and an asset base of active members. I won't go through them all, but it's the same for cooperation or collaboration, prevention and added value. For each principle-based goal of the Act, there is a potential read across to the credentials of not-for-profits. And this slide shows how the 5 principles of the Social Services Act are closely aligned with other key Welsh laws and policies. Healthier Wales uses almost identical language. The Future Generations Act talks about involvement rather than co-production, but the intention is the same. And the foundational economy has its own terminology, but there is a clear overlap of outcomes and approaches. So the apparent credentials of social enterprises, cooperatives and charities might suggest that simply giving them more care contracts would lead to a whole raft of policy objectives being fulfilled. But the world is not that simple. On the whole, public contract regulations don't allow commissioners to award contracts on the basis of organisation type. Sections 20 and 77 of the regs do provide a bit of wriggle room, and we would be happy to explore this with anyone interested. But the general rule is you must provide a level playing field for all providers. And as I've said already, the reality is that we currently depend on private organisations for a lot of care services, and some of them are very good. And equally, we can't safely assume that not-for-profits will deliver the multiple outcomes we need for sustainability simply because of their organisation type. It helps to see the Section 16 duty as a doorway for everyone to come through rather than as a barrier to keep anyone out. When it comes to the letting of care contracts, instead of focusing on the label of an organisation, commissioners and procurers should perhaps focus on specifying, scoring and measuring the outcomes they want. And they should aim for multiple outcomes against all 5 principles of the Act and by alignment, other policy objectives too. This is the first of my how slides, and it picks up on the point about specifying and scoring. On the left is the principle-based agenda that commissioners should build into their specifications. On the right are the attributes that providers should be trying to demonstrate. This is not the only commissioning activity required for the promotion of social value models, but it is the most obvious tool in the market shaping toolbox. Develop tender specifications and award points to those who best meet the criteria. All commissioners will be familiar with this tender scoring approach, but using it in order to shape models of delivery and achieve multiple strategic objectives is a new challenge. And what commissioners have told us is that they require leadership support and ongoing opportunities to experiment and learn. Today's report and the offer of workshops to follow is evidence of the Welsh Government's support for the challenge and for Pan Wales learning. This is my second how slide. The road to social value is not just about tendering or about putting all the obligations for principle-based behaviour onto providers. What happens before and after procurement is crucial for long-term change. Commissioners need to role model co-production and collaboration as an ongoing activity. And they need the capacity and the support from leaders to walk their patch and find out what is working and who needs help. That way they can learn more about what to buy and from whom, and they can build trust and create ownership of the change agenda. And measures also can help to keep multiple outcomes in focus during the months and years after a contract is awarded. My final third how slide argues that we need commissioners to build capacity beyond the market. It's easy to lose sight of the fact that two of the key principles underpinning Section 16 and Part 2 of the Social Services and Wellbeing Act are completely dependent on the involvement of citizens and communities, and not just their passive or tokenistic involvement, but their equal or even predominant participation. Co-production requires citizen and community voices and assets to be valued and mobilised. Prevention requires citizens and communities to take some responsibility for their own well-being and to have information and activities which keep them upstream of care. So if commissioners are going to proactively seek to switch on unpaid self-help capacities and switch off avoidable future demands, they need to think citizens and communities. Excuse me. This slide suggests what might be relevant commissioning goals for this. You may have read them all by now, but I'll just read out a few. So commissioning goals would be that more people are able to obtain what matters to them without direct recourse to public services. More people are engaged in helping each other at the family and community level. I'll just skip to the last on the list there. A goal could be that there are valuable citizen-led organisations in every community of viable size. If we could get all of these goals achieved and in place, I think we would be turning the vision of sustainable social services into a reality. And here's some suggested commissioning activities for building capacity beyond the market. Develop a network-based system for obtaining insight into how citizens and communities are doing, and not just within the social department or even within just health and social care, but across the whole panoply of local authority responsibilities for wellbeing. Evaluate information, advice and assistance systems and invest in their improvement. Use grants to support community initiatives. Build a locality orientation into care contracts wherever appropriate. And use social value forums and county voluntary councils as vehicles in support of citizen empowerment and independence. If commissioners haven't currently got time for this sort of activity, the question arises, is it because of more important priorities or less important distractions? Or is it more fundamentally still because we need as a country to invest more in our commissioning capacity? Wales has been described as having an implementation gap, with great policies aimed at empowering communities, but no capacity at the local level to turn these policies into realities on the ground. I guess there is some truth in it, but certainly not everywhere. And it would be good to surface some case studies of the great efforts that are being made already to build capacity beyond the market. Here's a reminder of core messages before I close my bit. Implementing Section 16 and Part 2 of the Act is all about creating a sustainable pattern of services and supports that enable people to achieve great wellbeing outcomes. It means using the principles that underpin Welsh wellbeing laws and policies, principles like co-production, collaboration and prevention. These principles are not just about achieving great outcomes, they aim for sustainability by making the best use of all available resources. That means shaping the market so that more and more provision is delivering on the principles and adding social value. It also means empowering citizens and communities inside care provision so that it delivers what matters to them, and outside care provision so that potentially they never need it. This is a transformational agenda, and its relevance is reinforced by the requirements of other Welsh laws and policies. But the focus of regional partnership boards since their creation in 2016 has been much more clearly linked to Part 9 of the Act than Part 2. A review of their terms of reference will show that the principle and practice of co-production is either not included or is misconstrued as interagency collaboration. They also make no reference to duties under sections 15 and 16 in relation to the development of preventative services. The focus on high-level statutory activities such as population assessments and the pooling of budgets has left the transformational citizen-enabling requirements of the Act on the outer margins of planning and commissioning. This isn't what the commissioners we have spoken to want. But it can be a lonely place for a commissioner pushing for change if many of those around them have no ownership of the change agenda. They need more allies and a clear message from Welsh Government that Part 2's hour has come. Again, Welsh Government's funding of today's report and the work programme to follow is a very clear message of their support. So, that's a quick run through of the first section of our report, which surfaces the what and why of social value models and the principles that need to drive this agenda. It also starts to surface some of the hows, scoring for more and better outcomes, role modelling, co-production and collaboration before and after procurement, building capacity amongst citizens and communities. Each of these hows could do with its own programme of developmental workshops. And that's what we hope you are going to sign up to after today. But as a taster of what commissioning for social value and multiple outcomes can look like, and of what we can learn from each other, I'd like now to hand over to Sian Griffiths from Gwynedd Council to tell us about the work they are doing to transform home care. Thank you.
Okay, thank you, Adrian. Yes, I'd just like to share with you for the next kind of quarter of an hour or so the transformation work that's going on in Gwynedd and has been ongoing for quite a few years now. I came into the work a couple of years ago, so I'm quite new in terms of where we're at in Gwynedd. So looking at redesigning and commissioning for social value in terms of home care. So in Gwynedd, what do we want to achieve? Well, as Adrian was saying, we obviously want to achieve great well-being outcomes for individuals in Gwynedd by actually helping people to live their lives as they wish to live them, not as we wish them to live them. So it's actually empowering people to be as independent and happy as possible in their lives. And what we want to do is make sure that we are actually able to do what matters properly. At the moment, we're not, and I'll go into why in a moment. We want to be able to build relationships at a very local level between health workers, social care workers, home care providers, and of course, individuals, their families, and communities as well. We want to be able to collaborate locally and co-produce solutions to local issues and challenges. So to find out what those issues are and work together to find the solutions to them. We want to change our commissioning and procurement processes so that we can embed the principles of the Act within our contracts. We want to improve staff terms and conditions and wages across all providers, so across the providers in the third sector and in the private sector as well as the council itself. And we want to ensure that we can jointly commission with the health board so that we are actually working together and not against each other. So that's what we want to achieve. What's the situation currently? Why do we need to change? Now the red there on the map, as you see, is Gwynedd. Now we are a rural, sparsely populated area of Wales, where we have a very high percentage, of course, of elderly residents living in the area, which does mean that the demand exceeds the supply that we have at the moment of staff and providers. So we do have many providers scattered throughout the country, which is on one hand a good thing because we've got a mix of independent providers as well as the council itself. But on the downside, they are scattered around on a very ad hoc basis. It's not planned in any way. We do spot purchase the packages of care through a central brokerage system in the county. And it is, we are following a traditional time and task model, which is not at all flexible. It's actually giving people a prescription of care, not what maybe they actually need in order to get those best outcomes for them. So we can't actually focus on what matters properly to that individual because of the inflexibility of the system that we work to. And we're also bogged down in bureaucracy. There are mountains of paperwork and a lot of duplication going on between the different sectors out there in the communities. So that's one of the reasons why we need to change, but we wanted to look a bit more closely at the systems that we're working with and within at the moment. So using the Vanguard method to do check on these systems, we worked really closely with a home care provider from the third sector in the north of the county. And what you see here before you is their learning about their present system. And this is going back a few years. So you see the circle there on the sheet, the big cheese, and you can see the blue colour is taking up most of that circle. Now this is where they were spending their management time, and the blue there is the time spent on the rota, so getting all that sorted, very, very complicated rota system, on the invoicing, on staff issues, on expenses, timesheets, paperwork and filing, passing on information and such like. The red there, which is a bit smaller, the red section of the cheese, if you like, is the time they spent chasing social workers and health professionals. So emails, phone calls, that kind of thing, and also compliance, self-management, staff management, sorry, seeking permission. And then the green, the tiniest bit of the cheese, is actually the direct contact that they had with people, with individuals or their families, to try and improve the quality of the care and the support that the people needed. And you can actually see straight away that there's something wrong there, can't you? The green there is tiny, where the green should be the biggest bit of the cheese. So they looked a little bit more closely and looked to map the processes that they went through in order to be able to deliver care to people in the community. So look, if you look at the top left-hand corner of the screen, you can see the red arrow with social worker there. So the referral comes into a social worker, and the social worker does their assessment and tries to get to grips with what matters to that individual. They develop their care plan, and that care plan is then sent to our central brokerage team. And they then try to find a home care provider that will be able to deliver that care plan. Now, this is very ad hoc. They send out an email, and whoever comes back on a first come, first serve basis will get that care plan contract, so a spot purchasing contract. Then when they get the care plan, this flip chart is the steps that they need to go to before actually that first call happens. So here we have Mrs. Jones, who lives in Bethesda, needs 4 calls a day. bed at 9. And in order to be able to deliver that, they have to go through all of these steps. And a lot of this is to do with paperwork. It's to do with sorting out the rota, amending the rota, and this kind of thing. And then all this has to happen before that first call happens. And this can take between 2 days and 2 weeks. So the person, the individual is maybe still in hospital, or at home. The family has to step in. It depends on the situation. But when that first call happens and the home care staff go into the home, they will find out maybe that the person will need more help, or maybe that the person will need less help, and that the actual care plan needs to be amended. So they have to go back to social services, and so the circle begins again. And so you can see that this is a very kind of bureaucratic process that we go through. So obviously something needed to change, and we looked at designing a new model, a new way of working. So what does this actually mean? It actually means that we're looking at bringing together staff from health and social care into an inclusive, integrated team on a very, very local level. And home care providers will become an integral part of that local team. So that means building relationships on a very local level. So building trust, respect, and credibility on a very local level, so that all the staff involved can understand the local situation and the situation of each individual that comes and asks for help, so they can actually spend time discussing and getting to grips with actually how to realise what matters to that individual. So it's a continuous assessment. Working as one team, it's not just one assessment and then go off and do the home care package. The home carers can actually feed in the information that they get from their daily, from the daily time that they spend with these individuals. So of course, flexibility is key to this way of working within these local teams. So looking at Gwynedd, we're splitting up Gwynedd into 5 areas and then dividing those 5 areas into 16 patches. And then there will be a CRT, community resource team, within each of these 16 patches, with the home care provider working closely within each of those teams in the patches. So of course, we need to develop strong community networks, and the teams need to know and get to know the community and the services, the community services and third sector services available or not available within that community. So locally, they need to understand what matters and focus on strengths, on networks and the local support available. Collaboration is key. Collaboration within the team, with local groups, with enterprises, be they third sector or independent. So everybody works to the same ethos. Building community capacity based on the need in that community and filling the gaps if there are gaps that need to be filled. So weaving professional and community support. And there's a key role for home care providers, of course, because they are the people that know their community. They are the people that know the individuals that they support and that they care for, and they can bring that intelligence into that local team. So trialling the new model, we have been working very, very closely with home care providers and third sector organisations in various parts of Gwynedd. So what has this shown us? What have we learned from the work that we've done to date? We've learned that we can better understand what matters and provide more tailored support when we work in this way. We can put more focus on outcomes and less focus on tasks. Some people will obviously still need time and task. You need to get to some people at a certain time in the morning or at a certain time in the evening, but we can put more focus on outcomes and on realising what matters to people. And by doing the right thing, we can actually reduce costs in the larger system. So reducing hospital admittance, for example, and of course that means the prevention agenda. It means we can get positive outcomes for staff as well as for individuals, and staff have told us that working in this way gives them much greater pleasure in their work, because of course they can actually get involved and do what really matters to people. But still there are barriers to overcome, and we're learning all the time, and we're working towards our goals.